everybody. Good afternoon. I am Liz McNamara. I'm one of the assistant administrators. I'm one of the assistant administrators here at Harborview Medical Center, and I'd like to welcome each and every one of you to our, what I hope is the first of many adult family home summits. With our goal today is to meet and greet, do a little education, do a lot of discussion, and really start that partnership that we all strive for to take care of our collective patients and clients. So I thought to frame our discussion today, I don't know how many folks know anything about Harborview. We're certainly sponsoring this on behalf of all of UW Medicine, but since it's in your own house, you get the opportunity to sort of talk about your own place. So I thought I want to share just a few things about us, and we're owned by King County. We're managed by University of Washington, and we're governed by the Board of Trustees appointed by King County. We, in 1877, were the first King County hospital. In 1894, we were the first King County hospital in Georgetown. And in 1931, we moved to our current site, and we had our new name. In 1946 was when they formed the UW Medical School, and in 1967 is when we had our UW affiliation with King County. We emerged as a regional and a national leader in trauma care, pre-hospital care, medic one, and burn care. I think that's what a lot of folks know about Harborview. They know that we're the level 1 for a 5-state region. How it fits into UW Medicine, it's just kind of helpful to understand that perspective. So UW Medicine, we are one of the UW Medicine entities, as you can see. UWMC, Northwest, Valley, UW Neighborhood Clinics, UWP, UW School of Medicine, and Airlift Northwest. We also share in the ownership of SCCA and in the Seattle Children's Hospital as well. So we're mission driven, and I'm going to share that with you because we're very passionate. Who used to work here? Right? We live and breathe it, and I'm really happy to share. We're owned by the citizens of King County, managed by UW, as I said, and governed by the Board of Trustees. In 1989, we got our first $179 million bond for a new trauma center that we completed in 1997. Welcome. And in 2001, we had a $193 million bond for a seismic upgrade, and we expanded our beds. And we filled them like the next day. Seriously, we opened it and they were full. It was unbelievable. So, what's our priority population here at Harborview? This is this is as defined by King County: people living with mental illness, substance abuse, or STDs, low-income people without third-party coverage. You can see this is a little old. Non-English speaking people with low incomes, people who have experienced domestic violence or sexual assault, people incarcerated in the King County Jail, trauma and burn treatment, and of course specialized emergency care. We are 413-bed acute care hospital. We have over 17,000 inpatients, over 247,000 clinic visits, and 64,000 ED visits a year. We operate at 95% occupancy. You can see we do a lot of surgeries. We have over 4,000 FTEs. All our docs are with UW, and we're a leading training site, which is also part of our mission. We've completed a lot of NIH-funded research as well, and in those patient population areas. So it's not just trauma research, right? We're at the forefront of the HIV research. We've done a lot of great work around that. So, as you can see, we're the only level 1 adult and PEDS center for a 5-state region. We operate on a break-even margin. We're one of the few safety net hospitals in the country that gets no operating dollars from the county. So they don't fund us at all. Nationally, that's very different. So in fiscal year 14, we gave $168 million in non-reimbursed care, charity care. We complete about $25 million per year in PI initiatives, trying to improve our quality of care while trying to be fiscally responsible in that arena. So there's a lot of outside influences on us. We have a lot of internal influences, as you can see. And actually, we're pretty proud of this number, I think. Those of you that sort of know us really well, we take a lot of pride in that. And again, these are our mission patient populations. We've got the Pioneer Square Clinic and Outreach for the Homeless, Community Behavioral Health Center. The Medicaid expansion. We had greater than 4,000 enroll kind of right off the bat with us. Medical respite program, interpreter services, community house calls. So we really take to heart the fact that we're part of our community, and we want to influence that and take care of that as well as the people that just happen to be in our building at the time. So we've talked about kind of this, and that's the building as it looks today. So our inpatient folks, as you can see, 45% are from right here, 16% are other King County, 34% are out or in other areas of our state, and then we have 5% of folks out of state. So over 60% of our inpatients come from here, Seattle and King County. And our outpatients, as you can see, 66% are right here in the city proper, 17% are other King County. So again, we're really proud of the fact that we're so embedded in our local community. And that's really what I want to share, just to kind of flavor our discussion. And the reason why we wanted to reach out and get to know folks is to be able to work together more, because your clients or our patients or their patients, we're all just sort of one group, and that's what we wanted to do today. So any questions? You guys have an agenda? We are really super excited to meet you guys, really super excited. What I think I'd like to do is take a minute, since I told you about us and about Harborview. Do you want to just do a quick round of who you are and where you're from, and then we'll get to our first speaker? Sound good? So you're eating, so I'll start here.
I'm Joanna Elliott. I'm a nurse, and I've had my adult home for 24 years in Shoreline.
Excellent. I'm Karen Lowe. I'm an RN. I've had my home about 2 years now. I've been a nurse for 25 years, and I did work at Harborview for a while.
My name is Dee Burris. I have several homes on the east side, and I've been a nurse for over 40 years.
My name is Mary Prince, and I'm also a nurse, and I have a home in Renton, and I've been a patient at Harborview.
In the trauma department.
I took good care of you.
You did, very good.
Good.
I'm Rolene Fryer, and I have a home Golden View in Valor, and I've been in business there for 20 years, and I've been an RN for over 50 years, and I'm still alive. And one young nurse came to the home one day and said, "What kind of a nurse did you used to be?" And I pinched myself, and I said, "Oh, I think I'm still there."
Yeah.
And she wanted to die, but anyway.
Oh my gosh.
But it's been a wonderful career, and like when I decided, my staff was telling me I need to.
Awesome.
I'm Wendy Mitchell, and I've been an RN for 39 years. I have an adult family home in the Bonnie Lake area, and I used to work at Harborview too. Burn Center.
I'm Therese Gallagher. I graduated from UW in 97 nursing school, and I work at Bailey Boucher House in admissions.
I'm Betsy Jansen. I'm a program manager with Owen Community Services, DSHS.
I'm Carmen Moisey. I have an adult family home for 11 years, and I'm nurse for 6 years.
I'm Cynthia Salazar-Rubio. I'm a nurse, and I have adult family homes in Kenmore, and I've been a nurse for 35 years.
I'm Esther Alvarez. I have a home for 16 years in Belleville. I'm a nurse for about 7 years.
My name is Ty. I have a family home in West Seattle, and been in business 22 years, but my own 10 years.
Excellent.
My name is John Ficker. I'm the Executive Director of the Adult Family Home Council.
I'm Diane Young. I have 28 adult family homes that I supervise as nurse delegator and do assessments for them. I'm this year's president of the Adult Family Home Nurses Association. And I worked on Old Five Center with George Dix many years ago.
Nurse Jackie, who's our Chief Nursing Officer now.
And I'm Christine Danforth, and I'm from the Olympia area, and I'm a nurse delegator, and I've been RN for about 30 years now.
And I'm Andrea Parker, and I'm a case manager with Molina Healthcare.
I'm Esther Martinez, clinical liaison for Proud America, work closely with the
Teresa Espana, I'm the supervisor of the hospital unit at Home Community Services.
I'm Jean Canilio with King County Behavioral Health and Recovery Management.
I'm Sunny Levin. I'm a program manager at the Outpatient Mental Health and Addictions Clinic here at Harborview Mental Health, and we manage PCS
Owen Riley. I'm a social worker and I'm a lead clinician on that expanded community support program.
George Dixon. I'm the lead clinician for geriatric psychiatry service downstairs.
I'm Terry Jo Putney, and I'm a peer specialist down at Harborview, working also with expanded family homes.
I'm Josh Spell. I'm a social work student, and I work with Owen.
I'm Deb Epperson. I've been a nurse for 29 years, and now I'm working with myself with sound transitions. I'm a nurse, and I help families who have primarily elders that need 24/7 care.
I'm Andrew Heinz. I'm social work lead for Snoqualmie Valley Hospital.
Elaine Baker, I'm nurse case manager, and I've been a nurse, I'm afraid to say, 40 years. And how I hooked up with this is Ella and I do a lot of work for them independently, and I do assessments in group homes and help set rates for Ella and I when there's Ella and I patients in there.
My name is Louise Simpson. I'm an administrator for post-acute care for UW Medicine. I'm doing work on behalf of Northwest Valley, Harborview, and UW Medicine, trying to partner with community partners better.
Hi, welcome. I'm Glenette Older. I'm the manager of the Geropsych Clinic at the Mental Health Center, and we work closely with many nursing homes and with adult family homes as our patients are placed there.
Bonnie Conley, I'm the director of social work here at Harborview.
I'm Carrol Alvarez. I'm the clinical nurse specialist for psychiatry, and part of what I do is develop care plans to help nurses care for patients whose behaviors are interrupting their ability to accept that care.
I have to say, I worked in O'Kane's nursing home back in 1971, waiting to get into nursing school.
Yeah.
And that was before we had licensing surveys in nursing homes. And they passed the federal regs to get licensing surveys in. And the very sweet little RN that hired me while I was waiting to get into nursing school was gone after the first survey. And Carrol Alvarez was hired to come and show us how to run a nursing home.
I was way too young to do that.
She came in with a stethoscope around her neck, and we thought, why does she have that thing around her neck?
That's right. Bonnie comes from the yoga, and I'm a nurse navigator. I work independently, but I have a lot of colleagues here.
That's great. Well, that's awesome. What an amazing group and so many connections, right? I mean, that's incredible. So when we've been talking with our partners saying, you know, what are some of the issues that we come up with? What are some of the things that folks might want to hear about more? That's how we sort of crafted this agenda. And I really want folks to be able to take one of those feedback forms too, because like I said, I hope this is the first of routine meetings that we're able to have. So we want to hear from you guys. What do you want to hear more about? What can we help you learn more about? So I'd like to introduce George Dix, who's going to talk. There first? I put you first, George. You want me to? I can change it up. Man, I'm telling you. Right? So George has over 30 years of experience as a mental health specialist, has done a ton of training, and is our internal go-to and a lot of external go-tos in terms of how to care for this very special patient population. So.
Thank you for allowing me to speak to you. My name is George Dix, as indicated. I am the lead downstairs in the Geropsych program. I've been doing this work for over 30 years now, and it's nice to see familiar faces, colleagues. Etzel and I have a long history. We used to bang heads a lot, I'll just say that, and then we now are allies and have been allies for a long time. We provide services to 6 contracted nursing facilities. We wish we were in more. We have many, many clients that live in the community and adult family homes as well as independently. And as you might imagine, as a person in the system, we interact with a tremendous number of other agencies and providers. My little part-time job is that I've spent 25 years teaching out at Edmonds Community College, And one of my courses is managing difficult behaviors. It is like packed every quarter. And so this is a real issue in many ways, in every level. And I just want to talk with you. And again, I like a dialogue. This is a very sophisticated group. So it's not going to be basic dementia today. It's a very sophisticated group. But we will talk about the issues that come up when people transition from a stable situation, a relatively stable situation, into the long-term life in an adult family home, and the challenges presented by them and for you. And again, a focus on non-pharmacological interventions into some fairly predictable behaviors. So I'd like to start by, again, thinking about the background of people who come into your facilities. I'm very aware, how many of us have spent more than one night in a hospital? Okay, good. Then you know you don't sleep in hospitals, right? Okay. So I've had some experiences that allowed me to live in a hospital for up to 21 days at a time. And I can tell you that is really a tough situation to first have some crisis happen in your life. So many of our residents so many of your residents are there as a result of a fall, perhaps, or the initial event was some kind of fall or fracture. When that person then goes into the hospital, is treated with pain meds, they're in crisis. If they have any form of dementia, that's going to become exacerbated. All of us experience increased anxiety, and I think that's something I want us to always keep in mind as we talk about all of this stuff. It has to do with anxiety, increased anxiety, and how we all respond to anxiety. So this person has had a crisis in their life. They're again going into a hospital where they're going to get pain meds. They're going to be surrounded by unfamiliar people. All the cues, so again, sophisticated group that you are, you know that our clients who have dementia, whether it's vascular or Alzheimer's, Lewy body, the variations, whether that's HIV, MS, alcohol, are disoriented and very, again, vulnerable to emotional escalation. When people are disoriented, it results in confusion. Who are these people surrounding me and what are they doing? Again, if I'm in pain, that makes a very turbulent environment to live in. So I go through the hospital experience with sleep deprivation, pain meds. One thing that happens routinely, it's happened recently with my clients, when you go in the hospital, your meds change. When you get out of the hospital, they're different than when you went in and different from the routine medications. I've had clients literally in this past week who had acute reactions, deliriums, as a result of these medication changes that were done abruptly, i.e. certain antidepressants should not be cut off instantly and resumed instantly at full dose. So often there's a lack of that consultation with other providers who are not doing the physical stuff. We forget to get the psych consult involved. So that's something I would start right out with, encouraging you to look for the psych consult if someone comes to you or your facility with a behavior problem, or if that's one of the issues. Did they have a psych consult? Has delirium been ruled out and treated? So they're coming into your home, a whole new environment, their cognitive map is no longer valid. They're coming into unfamiliar people, and while I look around the room, I see very strong, clear English speakers, but I don't know that all of your workers are strong, clear English language speakers. And I raise that because we're talking about older adults in general who have age-related sensory change already, even the healthiest of among us. I have presbyopia. I know that hit, sit, fit, lit to a person with presbycusis is extremely difficult to sort out. So it's really important that we approach people at eye level, strong and clear language, simple language, I heard that mentioned, very as simple language as possible, with a smile and orientation. This is who I am, this is what I do. Mrs. Jones, what do you think you're doing here? Who do you think I am? Mrs. Jones, tell me what I just said. So we want to up the cueing. Again, older adults with dementia are cue dependent. They look to the outside world, the people around them, to know how to react, to know if they're safe. Because safety, think of yourself being lost in the department store when you were a little kid. Most of us had an experience of being lost in the world. Well, I want us to remember that's pretty much where our clients are when they come to a new facility. They have very few touchstones, so they're looking to people to provide those touchstones for them. So, ongoing orientation. Well, I told Mr. Jones who I was yesterday. No, that's not enough. Today, repeat who you are to Mr. Jones, your role, offer that reassurance again, and then I think we always forget to ask, how can I help you? What can I do for you? The classic, the delusion, the parental delusion of, where's my mom? Where's my dad? Have you heard people do that before? Yeah. So we don't reality orient people, i.e. we don't say, oh, don't you remember going to your mom's funeral? Da, 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 da. No, we don't say stuff like that. Because that's what reality is, right? Okay. No, what we want to know is, tell me about your mom. What would you do if she was here? Tell me her name. What does she look like? Come, I'll walk with you. Show me where you saw her. You trying to lower the client's anxiety. You're trying to establish yourself as a safe, desirable person, the therapeutic alliance. We aren't getting anywhere, by the way, without that therapeutic alliance, without that therapeutic relationship. We're trying to present ourselves as an asset to the client, that I'm here to help you. I know some things that maybe you don't know and that can lower your concern and your worry. And by asking them what they need, it shifts that attention away from their distress, and it helps them start to think about themselves in a constructive way, and again, to see you as a positive ally. Pain. When people come from the hospital, you and I know that they are not comfortable necessarily. And as the day goes on, pain may be minimal in the morning, but as the day goes on, that pain becomes more and more. And also at the end of the day, people are sore. Again, I've had several abdominal surgeries, and I can tell you that night is a rough time for a person who's got a wound that's healing. And so be careful about pain meds. Well, you know this. Be careful about pain meds. Monitor closely changes in mental status as a result of those pain medications. Pain meds need to be effective but minimal. Many of our clients, many of your clients are going to have concurrent psychiatric illnesses associated with their physical problems. Many of our clients, again, the folks that we work with in the mental health center, many have had lifelong disability, lifelong challenges around their mental health symptoms. Those symptoms generally, as much as we would like to imagine that all that stuff goes away with the medications and with groups and all of that, that's not so. That's not so. Our clients, I'll say this, my first experience with a nursing home was in a place called Cherry Heights. You had to have been around a long time to know about Cherry Heights. And Cherry Heights at the time had the largest number of psychiatrically impaired customers outside of Western State. So I went from inpatient lockup unit where everybody was locked up, restrained, etc., I had seen a couple of clients who were actually in our unit a week before, now in Cherry Heights. The doors are unlocked, 4 floors of essentially mentally ill people. They had their own culture, their own society, their own love affairs, their own money for cigarettes situation. They were a community. That Cherry Heights taught me so many things about trusting folks who have these psychiatric diagnoses. And it taught me so much about how what we now call recovery, returning control, returning choice, respecting the individuality of our residents. And I watched them be like normal people in the, Cherry Heights was a little town. And I learned to love it, and I'm sorry that it had to be dissolved. It was an excellent place. But again, here were medications being used, but symptoms were not abated by any means. Their symptoms were active, but they were still living together. They had, like I said, token economies. They had all the components of relationship. And that taught me that, again, recovery is a real thing, but it's idiosyncratic and it has a context. And so, again, this was a community. We try to keep our adult family home people engaged in their communities, not just sitting quietly in the adult family home. That is not an acceptable situation. I know we all like quiet. When I go to a nursing home and everybody's quiet, I don't feel good. I worry about that. People aren't quiet. People are interested in each other. They interact with each other. I expect the staff to interact with each other. So getting to know the lifestyle of the resident, and when I say that, what's the daily routine? What does George do in the morning? When I was a kid, I was raised in the South. People take showers at night in the South because it's hot and sticky in the day, and it's so much nicer to get into a nice, clean bed without all that stickiness, right? And you sleep better. Now that I'm a Northwesterner, in the last 30 years, 40 years, I take a shower in the morning because it's a way of getting going. If I develop dementia, that becomes relevant as to what is the cue that says, George, it's time for you to take a bath. George, it's time for you to take a shower. Especially because I may not be aware of who you are. The last time I took a shower with somebody else, I picked that person. I suspect the last time you took a shower with somebody else, you picked that person too. Okay? And so consequently, our residents in the adult family home don't have that option, right? And so here's a concept I want you to keep in touch. Again, you think of yourself as offering a service to your residents. What you're asking is for their compliance. Every time you offer food, medicine, a treatment, request something from them, again, we feel like we're providing a service, which we are, because someone's paying us for that. There's somebody who's going to look over our shoulder if it's not done. But what we're asking from the client is their trust and their acquiescence to your authority, your judgment, to your request. So I want you to think about, that's not a little deal. Yes?
May I just suggest that in the adult family home, that's one of the pluses. We don't have to be that rigid. We can go with their lifestyle. I had a fisherman once, fished all of his life out here in Puget Sound, got up at 2 every morning for a shower.
Oh, that's great. That's great.
Because he went to work at 3
That's great. That's right.
It's okay.
That's right.
So I think in the smaller setting, we can be more flexible, we can adapt to their needs.
I hope that is true. That is exactly what I would expect. I think you know that is not universally true, and that is the challenge. But that is exactly what we would hope. Yes?
I would also submit that our adult family homes are their own community, right? That they also develop their own community under one roof.
That's what I would hope. That's right. And that's because someone is engaged in a fairly diligent activity of connecting people and again, getting to know them and providing a source of reminiscence and shared experience. And I think music is a great opportunity for that. Again, formally, like we just had the holidays. What did you do at your home? Tell us about that. Bring in pictures. Show us when you were a little kid. What did you do for your children? That's right. Again, I wish that were universally so. But I've often gone to facilities where I see everybody just sitting in front of the big screen television.
Come visit us. Yeah.
Yeah.
I don't think that's the way it is with us.
And that's right. I know that doesn't happen to anybody in here, so I'm not too concerned about it. But I want to be clear that as you supervise, I hear a lot of you are involved in associations. That you have some overview. Then I think that's really important that you be mindful of the environment of the adult family home. The environment, for me, in fact, the environment is the most powerful tool in managing folks with dementia. It's managing the environment. So again, having staff that are very clear, speak simple and direct, who know the client, who are comfortable, again, smiling and orienting, and who can elicit from the client their request, their trust, their interest. I have a client in one of the skilled nursing facilities who has gotten to know the aides so well. Half of her room, many of the aides are from Ethiopia and Somalia, and her room is decorated with beautiful hand-carved wooden icons from Coptic Christians and Ethiopian Christian church. And she knows and has the birthdays of the aides. She knows their kids. She has pictures. That's a success story for everybody. She's even advocated for them to keep their jobs as the facility goes through many changes. And so I know that can be done. I know that can be done. And I just want to, again, hopefully this is a way of us keeping in mind some of the things that facilitate that situation. I always look for issues around mobility. As a guy who grew up in the 50s watching cowboy movies, you know, a man and his horse, you know, that is a core American male identity, you know, that freedom of mobility. So many of us have illnesses or injuries that result in limiting mobility. I want us to really be aware of how powerful a force that is in perhaps creating depression. And it's really incumbent on us to help people figure out how to improve mobility. But not just that. Is there a place outside I can go to be in the world, to listen to the birds? I'm a bird feeder guy. I got 2 cats. The birds don't like that part, but they compromise, the ones that live. Anyway, and so we need to provide something in that way of getting away from you. and everybody. Don't you need to get away from people sometimes? Yeah. So, and I think that's one of the real issues in an adult family home. Many of us share a room. Many of us will share a room. And I've noticed this in the nursing homes especially. It's rare that roommates in nursing homes are buddy-buddy. It's kind of like they can be buddy-buddy with people down the hall and in other parts on the other floors and that, but it's a need for privacy. And I don't know if that's, I'm going to suggest that's a cultural thing, that's a very American thing, to have that need to have space around you. I need space, man, you know. That's an American thing. In many other parts of the world, and many of our other clients who come from other parts of the world, that's much less of an issue. And in fact, it might be contraindicated, that having a roommate and being in a smaller setting might in fact be a very positive thing for some people. But that's something we need to sort out. And so George is going to need a little space. He's going to need to be able to get out, to exercise some form of autonomy. So that comes in the form of choices. Yes.
Sorry.
Oh, don't be sorry.
A little education. Our census, I think we would agree here at this table, has changed radically in the past few years. Those folks that can go out and be independent, etc., are going to assisted living now. We are getting very medically fragile, debilitated patients. So they kind of can't go out and wander around the neighborhood by themselves without us chasing them down, of course. And many of them are no longer ambulatory at all. So we've had to change how we provide that privacy, which is pretty tough.
How do you do it?
Well, one thing is we give them private times in the rooms if they want them. The other thing is we take them out for walks. But frankly, when I used to take them on outings all over town, I can't do that anymore with these folks. First of all, they get exhausted too fast, and the transportation is difficult. I don't know if anybody else seen that these past few years. I mean, our business plan model has changed. So.
My thought about that is, again, back to the psychiatrically impaired patients. Because I do have fully mobile people who because of their dementia and their psychiatric illness, are residing in adult family homes in the community. And so I guess that if there are people who that does apply to, who will be getting out and about, who want to get out and about. In fact, again, part of the folks who are dealing in the ECS, Extended Community Support Program, some of those people are very vigorous and able to get out and about and be challenging to you physically. And so I want us to keep in mind how we can help reduce some of that energy, again, in an appropriate way that reflects an understanding of the client's skills and interests, structure. So getting people out, or giving an opportunity for physical activity. I think we all know there's no substitute for physical activity in terms of keeping one's brain working and keeping the positive energy in your life, i.e. something you can do successfully. I think that's one of the things with dementia, sort of as a premise. We always try to create success for that person because failure raises anxiety, creates distance between you and the resident. Again, reminds them of their deficits rather than what their strengths. And so we're very much a strength-focused activity. Assessments should be really focused on what is it that a person can do. It's pretty easy to identify the deficits. Everybody's focused on what the problem is. It's what are the strengths and what are the tools or the assets the client has that will allow them to be more productive, more in control of themselves, to be more responsive to you as a caregiver.
George, I think that's a great point, though. I mean, I think we get so used to, especially in the medical model, we do get really used to what's the problem list, what are the deficits, what can't they do anymore, right? So I think flipping that around a little bit is that's kind of an aha thing. Because especially as these folks get sicker and sicker, and there's less and less they can do. So that becomes even more important. So I can totally see how that would be a different sort of mindset, especially for those of us that are.
Well, then we have to bring it into the setting.
Right.
And anybody with good suggestions on what to bring in the setting besides music, art, and that kind of thing is welcome, because it's hard to think of. And again, then that levels the playing field. When we're no longer the caregiver, we're interacting socially.
Yeah, I think that's a very important point, is to get away from we're surrogate family. And even when I say downstairs here at the mental health center, the best relationships, the most functional relationships, sort of blur a little bit of the boundary between I'm the professional and you're the recipient of my professional services, because it's about being real. This is about real life. I think that's what's my value. This is not the client's life. This is our life together. I mean, this is not, I don't get this back. I don't get my 8 hours back every day when I die, and they say, oh, it was work time, you don't have to, that doesn't count. No, this is my life too. So I think it's important that we have a value of connecting. If you aren't a people person, then you shouldn't be in this business. But the fact is you are, because otherwise you wouldn't have stayed in it so long. It would have frustrated you by now.
We don't do this for the money.
I got that. I've never done it for the money, I assure you.
For 24 years of me doing this and taking care of people with Alzheimer's and dementia and psychiatric issues related to the geriatric patient, I can tell you this, that I've had 2 homes. I let one go because I could not get it to be like it was when I lived there. And maybe somehow people can have more than one home. I couldn't do it. I couldn't get the ambiance there. These people are my family.
Yeah, they are.
My granddaughter comes. Everybody's excited to see the baby. My daughter got married. Everybody's excited to plan for the wedding. They become your family, and that is the only way this is going to work. You need to have activities related around family time, functioning, playtime. You are there. You have to touch them. You need to give affection to them if they allow it, of course. And you have to understand
appropriate
affection. That's what I'm talking about. But you know, I'm Mama Bear at my house, and they know it, and they trust me, and I can do anything. And family members are surprised that I can get things out of my throat that they cannot. It's because I love them. I love them. It's true. And you can't do this for the money because we're making $9 an hour. Yes.
What you're talking about is positive transference as opposed to negative transference, okay? That is, I'm trying to remind people that, yes, we are all in this together. You've had nurturing people in your life before. Do I remind you of that? I hope that my casualness but competency, along with my genuine interest in who that person is.
The other problem that arises from my model is that I've had 106 deaths as of last week in my home in 24 years. And when you love somebody, a piece of you goes. And that's the problem that we all face, all of us, is because if you can't live with somebody 24 hours a day and not feel some pain when they go. And so that's where the professionalism comes, where you have to kind of surround your heart with a little gold.
You know, I have exactly the same experience, and I'll tell you what has happened to me now. I feel good that I had integrity with my clients who, when they do pass, that we have provided in the last few years really a good life for them. I can honestly say, again, in geropsych, we do preside. We have far more people die than anybody else in the clinic. There's no two ways about that. You and I are presiding over a decline. And that is what's going to happen at the end. It's that, have we had the integrity? Have we given honestly to the client what they could receive? And I must admit, I miss them, but I smile when I think of them. I smile when I think of Jane and Bob and all the other people. Yeah, right, Bob. He was hell too, wasn't he? He put Etzel, he had me and Etzel in conferences. Oh my goodness. But I 17 years I've walked with this guy, and I'm so pleased that finally near the end, Etzel took over. And so that is really for me and the accomplishment that we were able to create that same connectedness and appreciation for this man who was really a difficult person, but also was an interesting, fascinating person when you got to know him. And it required my advocacy on a regular basis. But also, I hope that in using that very difficult person, it also, allowed me to establish relationship with staff in a way that just coming in, talking to the client who's pretty quiet and going away. I have a much more intimate relationship with the staff where Etzel used to work. And they are my family now too. The staff is really important to me. So again, even the most challenging cases, and this fellow died exactly the way we wanted him to. In his bed, in the skill facility, surrounded by people that he could trust and he knew cared about him on some level. Yes, ma'am.
That's the issue, especially the nurses running adult family homes, working in adult family homes, is working so hard to train the caregivers to give people a really good death.
Things I found at Southwood, hi by the way. is that we all have to develop our coping skills with death. And so one of the things I share with them that's helped me, may I help them? Well, first of all, I utilize the hospice social workers. They were here last week, we had a number of this. To speak to the staff without me present, and that helps them as well to develop their own strategies. And people say, how do you deal with that all the time? Well, we develop different heartstrings than the family members or their close lovers. We have to. Otherwise, we can love them, we can be compassionate, we can't take care of the next person.
I don't have the baggage that families have with folks. And so that is the gift that you and I get. So I don't push families. I try to push families. I try to find a member of the family, especially again with our psychiatrically impaired clients, because this disorder comes on for men in their teens, for women in teens to their 30s. And so that's a critical time when their behavior can be so bizarre, disruptive, aggressive, that it really alienates them from their families, their siblings especially, for years and years and years. But I always try to look for a grandchild, a niece or a nephew, somebody, a cousin, somebody who wasn't so profoundly impacted by that behavior, and then to educate them. So I hope we educate family members about the nature of the disorder and why they see what they see happening with their loved ones. I think another expectation that families may have is that when folks come into treatment with us or they come into your home, that all of a sudden those problems go away. I always say, no, 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 no. All the same problems, actually now a little bit more. So that's the thing I always want to keep in mind when people transition from a fairly, I don't want to say stable all the time, but predictable situation to a new situation. Anxiety goes up, their coping narrows, and so there is a transition time when, especially new people to your resident, that are going to be more challenging sometimes than as time goes by and they familiarize, get oriented, et cetera, et cetera. But we should expect a little bit of a increase in activities, a step down in functioning from the hospital to the community. And I think, again, because our program that we're sort of focused on is this enhanced community support, we're talking about people who were challenging to begin with. Not just a little bit, but really challenging. They've had a lot of staff, i.e. the hospital staff is a greater numbers, not always more skilled, especially in these issues, because they're busy. They're trying to tend to task and not really have the time to focus on those individuals. So maybe what's happened in the hospital is we've taught people to act out, to get attention. You know, it's the squeaky wheel who gets the grease. And so they come to you with that cueing. And so you really have to help them say, this is a different place, these are the changes, what can you do? I think, again, let's empower these guys a little bit. Even the most demented people have some sense of their own integrity and what they desire, unless of course they're nonverbal, you know, or something like that. But if they're at all alert, we should engage them as much as possible and talk to them about what's happening to them. Yeah, you've been in the hospital with all this other stuff going on. First of all, you need a good night's sleep, you know? And, you know, so then let's see about your nutrition. Let's see about your who was in your life that you haven't seen for the last 6 months or whatever. That's offering them, what are we offering them? Hope. A return to something that's familiar to them psychologically. And more importantly, what we're talking about is return to ourselves. Our own, that's what we're trying to. So in addition to a good death, we're trying to help us all recover our core sense of who we are, a sense of our own well-being. So it's really important that we invite psychiatric practitioners into the mix, is what I would say. And that's the segue, right. And I don't want to, and I recognize that it's also not easy. This is not an abundant resource out there in the community. It's real. We got a long waiting list if you want an appointment in our clinic. But please try and get one. And feedback to the powers that be, the need for more people who are willing to consult with you. And when I say this, what I mean is that, again, this is a very sophisticated audience, but it really, the person from the outside, and this is the advantage of us going into facilities, who hasn't seen what's going on. When I see someone once every week, I can monitor their change in a more acute way than someone who sees them every day. And that's one of the 11 tasks that they have to do. When I come into the facility, I'm focused on my clients and the situation around them. So again, you all know this. When you have kids, they grow. It's the person who sees them once a year, or when they go back to school, who notices what the changes are. So that's the advantage of the odd man, the person who's the outside eyes on a situation, especially if they have expertise. Liz.
Oh no, I was just gonna.
Oh, those guys got to talk too.
You have one more question.
Yeah, okay.
Oh, yeah.
Yeah, please.
When you said, I have a client, she's in her 60s, she has frontotemporal lobe.
Oh, okay.
And we're up in the north end. So she was at Northwest Gero site for about a month. I don't know how many months ago. And she was let go. The sister had to find her own psychiatrist outside. Because she had been down in the south end in Renton and seeing a psychiatrist.
There are more resources down there.
So now everything's fine, but when you're bringing up, and I do have a lot of things for her to do and all that kind of thing, but I mean, so she's not on Medicaid. So she wouldn't qualify for the free bus,
the tier,
all those things.
Access,
right?
All that.
So I mean, her family's pretty much on her own if they want to hire someone to bring her to some sort of adult daycare or more stimulation.
And you know, you said the magic word. I would. You're talking about the way our system is constructed, okay? And that's so. One of the hats that I have worn is a member of Aging Disability Advisory Council, and going to Olympia and advocating for services, particularly two things. Volunteer transportation service, you guys know about those guys? Free. They'll stay with the resident during the appointment and bring them home. And I remember this was a big deal because the state was going to take the $1 million it takes to run that program, and we advocated hard with the legislators to restore those funds, which they did, because just think of how many people, how many millions of dollars that saved for the state in terms of transportation. So that's an option that I would consider.
But they would have to come all the way down here for any.
That's right.
From South Everett.
That's right. That's right. And that's, you know, again, how do we...
Not necessarily. So
okay.
We're working on different models, especially now that we're an ECS provider.
And also, we have clinics out in the world now.
We do.
That's right. I always forget about those satellites that we do, but I don't know if they're...
No, I mean, she does see a psychiatrist, but I'm just saying for the activities. And
Adult day program, and I can't... I really strongly encourage, if you can get people out into full life or whatever that option is, please do. But you know, here's the thing, senior centers are also good places for sure, and they are receptive to people. Community centers, I go over here to in Rainier Valley, and it's a Tukwila Community Center, are you kidding me? That's an ideal place. So if you're in those neighborhoods, they are fine places to let people, to escort people where they can, again, be involved in the community and get the proper kind of social stimulation.
And I think that's an opportunity too, and as we're UW Medicine, we've got Elise here, who's UW Medicine. From a Harborview perspective, we know that we transition our patients to the next level of care. They're never totally gone from us. So in terms of partnering beyond that inpatient hospital stay and helping that aspect, I think that's where we're going to grow as a system as well. So it's not like the family out there trying to find their own. What other resources do we have out there to be right? We can help with that.
Churches?
Behavioral therapy and such, that there are the neighborhood clinics that have behavioral health programs. So if they have an ECP, they get a referral to a social worker who does therapy and has a consultant psychiatrist. So they do
want to.
Yeah, there's one in
As far as
Florida.
this is doing. And now it's smoking point.
And now it's smoking point.
Well, as of, yes.
Yeah, see, I think that's the thing, that's just, we're just talking, I think this is the benefit of this group, and this is how we're gonna evolve as a group. I mean, I really do firmly believe that we are gonna evolve as a team and a group, and as we find out what do we wanna talk about next time, I heard a couple of really key things that next time this is what we're gonna dive into and share resources, and you go out and find something and bring it back.
Yeah, you know, today was kind of an initial start for me, so I didn't know exactly what you needed and what you wanted to hear. But
see, and I hear a role for some direct therapy presentations as well,
yeah.
right? So I think that would be, we already have our next agenda item, which means you're all signed up again for the next time. But I heard that, and then I also heard, how do we maintain our own resiliency as providers, because this is hard stuff, right? So those are two already topics that have sort of popped up that we all share, but I think we definitely can dive into those more. So
yeah.
Thank
you
George.
very
You're
much.
Awesome as always.
Thank you.
Thank you. All right.
My name's Sunny Levin. As I said, I'm a program manager at the Outpatient Mental Health and Addictions Clinic downstairs here in the Pat Steele building. And I'll let you introduce yourself.
Owen Riley. I'm the lead clinician of the Expanded Community Support Program.
So we wanted to talk with you just briefly about expanded community supports, and we have some key people from DSHS here: Betsy Jansen, Teresa, is it Teresa or Therese? Teresa Spagna, who we've worked with closely now. We developed this contract with DSHS to provide expanded community support services to people in adult family homes last year. Actually, it's been about exactly 1 year, January of 2015. And it is a program that allows us, Owen, essentially, as providers to come into an adult family home and provide support to not only the resident of the adult family home, but also the workers and the providers in the adult family home to come up with plans that help manage difficult behaviors. George Dix has been a key participant for us because he's really been helping us to learn how to do that. And so we have him as a consultant to kind of help us manage that. And then Terry Jo Putney, who's in the back, is one of our peer support counselors, who's also been involved with our program. And she and Owen kind of tag team in terms of going out and visiting residents, or I should say a resident, because currently we only have one person enrolled in this program.
Sign me up.
So what we're kind of here to plug today is to talk with all of you as adult family home providers and encourage you to get in touch with DSHS representatives, Tina Lee, Betsy Jansen, to decide if you would like to be an ECS provider.
I'm confused. Are you guys like nurse practitioners or
Social workers. We're providing behavioral interventions, but we also have a prescriber on our team, psychiatrists.
Yes. So part of the service does involve, actually in this woman's case, she comes with, you bring her, right? Owen brings her, yeah. So she comes with Owen to our clinic. He provides the transportation like you're talking about, but it also gives them a nice opportunity to connect and talk and get to know each other. Yes. That's the caveat.
That doesn't work for a lot of your folks, so.
Jeans?
Gotcha.
How many potential ECS spots are you going to have?
That's kind of open right now. I mean, the idea was that we wanted to enter into this contract so that we could start, providing these services and then see where it goes. And like I said, it's been pretty slow going because we're just kind of trying to get our feet wet and start developing some referrals. If I were to pitch a perfect plan, we would actually be following patients who are already in Harborview, who have frankly developed a pretty nice care plan with the hospital staff on the inpatient units that could then be kind of transferred to us and then carried over into the adult family home to make it a very seamless transition for the patient.
How far are you going
just staying and keeping to the county line of King County and going that far?
Well, for Harborview patients, we said that we'll can't go too far. I mean, again, if we get multiple people really far out, then that impacts the team. But the team's really committed to really want to give us a try. So, especially for Harborview folks that are here right now, or in the
Yeah, I'm thinking about Russell. What's Russell's last name? That has the psych home.
Oh, Phelps? Yes,
Phelps. And I think they're DSHS clients. He takes really tough guys, it's mostly guys. And he's in the shoreline.
He does not take DSHS.
He does not take DSHS.
But there are homes that feel like it's their mission to take DSHS.
Well, DSHS wants to know about those homes.
Yeah. And you know, if you help 40, 50, if you took the toughest client in 40 or 50 DSHS homes, that would be a huge service.
Can I ask a really naive question? Who is, I guess I was under the impression that anybody who goes into an adult family home has to be funded through DSHS.
No. None of them.
This is great. Yeah. So private pay, so it's families who are paying to have their loved one live with you.
Betsy has an answer for us.
I'll clarify for you. Adult family home owners need to be licensed by the state of Washington. Right. But they have an option to be contracted with the state of Washington to provide services to Medicaid
And John
residents. So, yes.
Yeah, currently, I think it's fair to say that about 57 to 60% of the available beds in adult family homes are currently occupied by Medicaid funded residents. The ECS program, that's okay. The ECS program provides services to, Betsy, do you know a number on how many ECS contracts? Because it's a very small percentage currently of homes that also additionally, because in order to be served on the ECS program, both the adult family home has to have the specific contract with the state of Washington, and the client needs to be considered eligible for expanded community services, which is actually something that, to the best of my knowledge, the ECS requirements for the client are not published anywhere that I've ever seen. So that would be another kind of interesting piece of this conversation as to what are the criteria for the resident, potentially.
So there are currently about 75 adult family homes that have an expanded community services contract in Kane County. So we're just talking Kane County. It is a statewide contractual option. So if folks outside of King County want the contract and they're eligible, they can also get the ECS contract. It kind of overlays the regular Medicaid contract that a provider would get to just open up services for Medicaid.
So they would just be on top of those services?
Yes.
So in essence, they're like a Medicaid patient, but they're given extra money to do these kinds of programs, correct?
Yes. And therein lies the biggest problem, are the rates. There's no way that I can run an adult family home successfully with lack of funding, which of course now is a well-known subject. And the state did a survey, I'm sure you remember, a few years ago, that cost them $500,000, and then 3 years later they came back to us and said, well, you know, you need more money, but we don't have it. And so the rate, I mean, with stacking, you can be paid $15 an hour this year, but we don't avoid that at all, which makes an hourly rate $20 an hour because of taxes, etc. And you have to pay these good folks if they're going to stay with you, and you don't want the revolving door syndrome going on. Cost of food has skyrocketed. I mean, butter, milk, you know, we live in the same world. We cannot do it on the money that the state offers, and that's not a secret. And it's sad, because I think these folks have the same right to this kind of care, a small setting, that anyone else does. And I don't know how to solve that problem.
Yeah. So I've worked with the ECS program at SMH, and most of the referrals come from Western State Hospitals. So are they now going to be able to come from local hospitals as well?
Yes, the Expanded Community Services Program started as a very small effort in a way to open up community options for folks that were in Western and Eastern state hospitals. And it grew over time and over the years so that now it is a COPES waiver service. So somebody that's Medicaid eligible that's eligible for our COPES program, and they meet certain criteria around behaviors or failed placements, or if they've had a psychiatric inpatient stay. There are a number of different criteria that people need to meet to be eligible for the program, as John alluded to. But it is now open to anybody that's eligible for COPES and Medicaid, and then the ECS program. So they don't have to be coming out of a psychiatric bed.
So is it documented anywhere what those criteria are?
You know, it's a good question. It's not, it's part of the COPES waiver program. It isn't, there aren't any WACs or RCWs that are associated with the program. So I can get you information about the eligibility and about the referral process.
That would be useful.
Yeah, because we wouldn't know how to get it out there if it's not coming.
We have our
from-
third agenda topic for next. Awesome. Great. Any other questions for Sunny and Owen?
Thank you for doing what you do.
Thank you for doing what you do.
Thank you.
Elise, did you want to say hello to the crew? Sure. Elise Chyet, hopping over from the inpatient side of the house.
Just doing double duty today. I just wanted to really thank everybody for coming to this first summit, and it sounds like it's been going really well for the first hour. Really, Harborview and DSHS and some of the adult family home providers have talked about this for a while, to really say what are some of the barriers for adult family homes in taking some of the complex patients from Harborview, and ways that we can build bridges. So this really, hopefully, is the beginning of some ongoing dialogue. It sounds like there's some other issues to continue having, and ways that we can really enhance that partnership. Because we agree, I think the adult family home is a wonderful setting for people. It's family, it's small, and being in an inpatient hospital is not where most people want to be. So ways that we can really help get our patients into your settings and support you in that is really what we're trying to develop as part of this process. So I thank you for being here, and we'll want to make sure we get all the speakers here, and then at the end, Liz and I will be able to maybe continue having a conversation about sort of other options for the future. So again, thank you very much for coming, and I will turn it back to Liz.
Thank you, Elise. All right, so next up, we've got Carrol Alvarez, and like I said, she's going to talk about building the whole person care plan and just sort of our experience in having that care plan follow the patient.
Hello. I have been a nurse about as long as many of the people that I heard introduce themselves here, 40 years. And a lot of that time has been spent consulting to nursing homes. I did that for about 6 years. And in essence, a career of consulting to nurses about how to provide care, as I said in my introduction, to patients whose behaviors interrupt their ability to receive that care. And Liz says that I'm going to talk about the whole person care, behavioral care plan, and then I'm going to hand out for you a list that's going to look like a skeleton of that agenda, because this is kind of the core of what goes into the behavioral care plans that I develop, but this is not resembling those care plans in that it's not individualized. And there's no care plan that goes into a chart that isn't specific to the very particular patient that the care plan is for. And I think one of the things that Harborview does really well, and the reason that I've stayed here as long as I have, 30 years, promising myself that I could leave in 2 years if I didn't like it. 30 years later, the reason I'm here is because it's a self-selected group of people who are very good at seeing behind the disruptive behaviors and the problematic behaviors and the challenge behaviors and the addictions to the person, to that little kernel of a person, and speaking to that person and then expanding from there. And so the care plans incorporate that. But these are some of the things that are inherent in almost every care plan. And the first thing that I find when I'm asked to consult on patients who are challenging is that not only do they come with their pre-existing adaptive coping mechanisms, they're attempting to get their needs met in the way that they've learned how to get their needs met. And it's not necessarily the way we in our institutional systems want them to get their needs met. And they may know no other way. So first of all, when I'm working with the nurses, I'm trying to figure out how we can respond to the behaviors that we're seeing and teach alternative behaviors at the same time. And once patients, my experience has been once they have an alternative way of getting their needs met, they pretty much, we don't see those old behaviors again. It's pretty amazing how fast those drop out. And some of the things that happen when they get in and the behavior persists for a while is that we fall into this pattern, even knowing better, we fall into this pattern of providing more attention to the aberrant, challenging, or non-adaptive behaviors than to the times when the patient's quieter or getting along all right. And it's just human nature, right? So you have a patient that's a little bit challenging, and you have to, and you are interacting with them completely appropriately, but maybe at kind of a lower level than when suddenly there's a crisis and you have to run in. You have to go in and respond to the crisis to make sure the patient's safe and the people around them are safe. That's a lot of attention at crisis point. And sometimes it can be a challenge to figure out how are we going to provide equal amounts of attention at non-crisis points. So, and I could give you a million examples of that, but we had a patient one time on one of our psychiatry units, and she just was not getting better. And so they asked me to help them develop a care plan, and I did a chart review because I always review the chart, and I always spend a lot of time talking with the patient. And I talk with the nurses about what's going on so I can get as full a plan as possible, or a full picture as possible. And so I review the chart, and it is so clear in the chart that when she's doing pretty well, she's perking along in the unit. People are noticing that on the unit. Her contact person is interacting with her occasionally. But when she's not doing well, a lot of people surround her, like 5 people. And then there's a discussion about whether she's going to go to seclusion or not, and whether they're going to have to put hands on or not. And that was happening at least twice a day. And I was like, how are we going to ever generate that amount of attention, 5 people surrounding you with a lot of intensity, trying to have a discussion with you about what you want and how you can engage in the way that we also want you to. And so that was the challenge. And it involved finding out, which I know you all already know when you have these patients in your facility for a while, finding out what were the things that were really rewarding to her. What did she like to do when she wasn't psychiatrically ill? What were the things that she took pleasure in? And then finding a way to make those available on a really predictable schedule. And then decreasing the amount of time people spent. First of all, don't have 5 people running up there having that conversation. Don't have all 5 people talking to her at the same time. And so it's kind of calming down the crisis reaction and then beefing up the responses at other times. And so that's kind of what this whole section number 1 talks about. And we do it inadvertently. We don't even realize we're doing it. And I'll give you another example that shows how easily that can happen. It happened on rehab. And we had a patient who was a high-level quad. And he had been he had a very problematic, he was 18, he came in because of a suicide attempt. He had a really difficult childhood. He didn't have a lot of skills. He developed an amazing array of social skills and coping skills during his time in acute care. He continued to develop skills when he got to rehab. And then I get this call that he's refusing medications and treatments and turns. And it's kind of new. I'm kind of puzzled by that. I review the chart, and you could just see in the chart notes the cascade of effects. The nurse goes in, offers to give him a medication. He refuses. And what do we do when a patient refuses? She starts to teach him what the consequence of the refusal is, what the medication is for. He's still refusing. Then she kind of bargains with him. It doesn't work. The next time he's offered that medication, he refuses. The same thing happens. Pretty soon he's refusing more medications. And the response is always the same. It's a very caring response. Bargaining with him, teaching him. He knows what these medications are for by now, right? Telling him what trying to make some deal with him. And then at other times when he's doing well, people are engaging with him in a socially appropriate way that they liked this guy, but it was a lot more attention and a longer conversation, I think, most of the time when he was refusing. So pretty soon you can just see he's refusing more and more and more things. So that's just inadvertent reinforcement of refusal, right? He got so much attention for refusing. And for people, negative attention, so this might not have been as pleasurable as social interaction and offering him a Diet Coke, but for all of us, negative attention is better than no attention. And for some people, like this guy, who had kind of an impoverished childhood, the more attention, even if it's negative, is preferable to just social engagement and low-level attention. So the care plan was obvious. It was kind of like, go in, don't teach him. don't bargain, don't cajole. He knows the implications now. He's been taking these medications for several months. He's been taught up the wazoo for the last month. So don't be teaching him what the medications are for. Go in and offer. If he says no, say, okay, I'll be back sometime when I have a moment in the next hour, and then leave. And come back sometime when you have a moment in the next hour and offer again. And if he refuses, say, okay, I'm going to chart it as refused, and chart it as refused. Other times, go in there and spend a little extra time with them. And the ways you all have in the adult family homes to spend extra time are way more expanded than what we have, but we have some basic things. If you sit down to talk to a patient in the facility, I'm talking about inpatient, and I know that you have way more options available to you, but in the inpatient setting, there's research that shows that if you sit when you talk with a patient, they will overestimate how much time you spent with them, and if you stand when you talk with a patient, they will underestimate how much time you spent with them. So the care plan was, when you go talk with him, when you're not talking about meds or treatments that he's refused, sit and spend a little extra time. It could be 30 seconds, right? It could be 1 minute. It has to be some extra time that you weren't taking before, but it doesn't have to really put a wrench in your schedule. And chat with him about his areas of interest. And when I put a care plan in, I always put what the areas of interest are. It has to really be important for that patient. It has to be meaningful for the patient. So this whole first one is just about inadvertent reinforcement of challenging behaviors and how to start turning that around. And it's very individualized, right? Because you have to know what is going to engage the patient and make them feel like you really heard them and that they belong here and they don't, right? What's going to be reinforcing.
So you're saying that bribing is not very, obviously not very therapeutic, but it gets it done.
I one time had a patient say to me,
some licorice gets a pill in every time.
listen, what are the primary reinforcers for infants? They're food and touch.
Mm-hmm.
So if you can touch the patient and it's not going to be aversive for you or the patient, then that's fine. Social engagement is just as good. And then what's the other primary reinforcement? Food, right? So I don't know if it's a bribe. I think it's things that we all need and respond to.
Here, take this.
Yeah. Well, depending on how you do it. Let's see. So this whole thing, number one, is all about that. And the last thing is really important, and it doesn't happen so much in hospitals. I think it happens way more in the adult family home settings. Talk about normal things. Do not talk about illness-related things. Do not talk about the requirements of the institution. Normalize the conversation as much as possible. This requires getting to know a little bit about the patient. Do they like football? You know, what did they like to do when they were, before they started getting sick? And then engaging them in that. And then I have a couple, so that's kind of, you'll see that at the heart of every care plan pretty much. But then I have a couple specialized groups. I have, number two is oppositional personalities. So these are often, not always, people who have a history of drug use and who've been spending time in the prison system. And now they're so ill that none of those things are available to them. But their personality structure has survived intact. Right. And now they need care. And the thing with those kind of patients is that they're often very oppositional. So if you suggest something, their reaction is going to be to say no. And then if you try to tell them why you're suggesting it, you're just going to increase the resistance. So the more we try to convince an oppositional person about why they should do something, the more entrenched they'll get in it. In fact, that's not only oppositional people, it's everybody. The more you argue your point of view, the more entrenched you'll get in it. And there's research to support that. So what we want to do with these patients is not give them the opportunity to say no so much, not give them the opportunities to practice that, but to just sort of say, well, okay, so you're not gonna do that. That's not necessarily my decision, but that's certainly your decision. That's fine. Another thing you can do is you can challenge them gently. People with these kind of oppositional disorders, with those the history that I just described, prison histories and drug use history, they like to be in control. They love to win a challenge. So what we want to do is teach them a little bit different way to get what they are requiring, or what they are requesting with their aberrant behavior, with their challenging behaviors. One way you can get their attention and get them to learn the skill, which they don't think they need to learn anything, is to just do a gentle challenge and then slip in the teaching. So here's an example of that. I was on one of the acute care units and we had a patient who had just lost, I know you're not going to ever get this kind of a patient, but he had just lost a gun battle with the police, which was why he was on our unit. And every time the nurse walked by, he yelled, "Hey, you know, unpleasant name, get yourself in here." And of course, nobody was doing it. And one of the nurses stopped and she said, and this is the challenge, right? "Are people coming in when you say that?" And then he blustered and he was like, well, and he justified why he had to do it. And she said, "Well, here's the deal. You could try this or you could try this." And actually, that behavior dropped out instantly. Once he had other ways of getting people in the room and people reliably came in, he stopped calling them bad names as they walked by. So just some creativity around that. The last special group I want to talk about is briefly is people with dependent personality disorder, people with dependent personalities, people who've always been taken care of by someone, or people who don't feel confident of their ability to take care of themselves, and that's been who they were their entire life. A lot of times, I mean, I have a family member, an in-law like that, who was the middle of 7 children and only got attention when he was ill, right? And so, you know, they would like that kind of a patient often wants you with them 100% of the time, and even that might not be enough. And they're frequently calling when you're not there, and it's the calling that can be kind of disruptive. And the best thing for that patient is reliable, predictable contact. Once they trust that you're going to be there at those reliable times, that's not as good as being there 100% of the time, but once they trust that those predictable times are going to be present, that calling out will drop out. And they may call in between times, and you need to check to be sure they're safe, so you just stick your head in and make that assessment and say, okay, don't forget, we're going to have a little chat in another 20 minutes, and then you step back out. Okay. And then I have one more thing on here that doesn't really have to do with the category of patients, but it does have to do with limit setting. Because I don't think it's possible to be around other people and be in relationships with people, let alone take care of them, when you don't have some opportunity to say, no, I'm not going to do that, or you can't have that. And you know, this is America where you can have anything you want, right? Nobody likes to be told any version of no. But there's a really nice study that came out of the University of Toronto School of Nursing a few years ago where they identified 6 limit setting styles. And I'm not going to review the study. It's pretty interesting, the 6 limit setting styles, some of which work for no one, like no, you can't do that. That works for no one, no surprise. The thing that tends to work the best for patients, for anybody, for any of us, this has helped me so much in my relationship with my kids, is to make some statement that is validating of their distress and shows empathy, and then provide choices. I know you want to continue to sit on the couch right now, and it's so comfortable there. You know, we have this or we have this, and then move to that. Yeah.
Oh, I can't hear you.
Oh. Validate, provide an empathic statement, let them know you sort of understand where they're coming from, and then provide choices. It doesn't work for people with such cognitive impairment that the choice isn't understood, or it makes them anxious because they're not certain what the choice is or what you're asking them to do. But for other people, having choices is key. Validation plus choices. And there are always choices, it's just sometimes I'm not quick enough thinking about them. But the more you do this, the better you get at figuring out what the choices are in any given situation.
You're love and logic.
And research supports it, for crying out loud. So when we have a patient that we have worked long and hard on with a behavioral care plan, Tim Meeks is a behavioral educator who puts care plans into the chart, and I am also a person who puts care plans into the chart. And with some of these patients, I think we'll be doing a little bit more of this, we have been letting the facility that they're going to know that we have been working with the patient. We make sure that the care plan goes with the patient. Often a nurse will go with the patient to help them settle in, a nurse that they know from the floor. And then Tim or I, whoever's been putting the care plan together and working with the patient, is available by pager or by phone. And I've certainly talked with people who've said, oh my gosh, now they're doing this and we're not sure we can keep them. And then I can just say, have you tried this? This usually works in this situation. Call me back if it doesn't work. Of course you can't keep them if they aren't tenable in your facility, but you know, it's just another little extra consultation based on the care plan we've established and what we know about the patient up to that point.
And that has worked really well because, like George said, you know, that time period where they've been here and then they go to another place is so anxiety provoking that that's when we often see those.
And that's just like DSHS clients?
So that's whoever comes from Harborview.
Not necessarily Northwest.
But that's where the education of the places you're placing, they have to understand that it's going to take at least a month to 2 months before that settling in process happens. And you can't expect that just because you have a bad first week. You've got to expect that you're going to have a bad first month. You know, and then people need to be educated on that and or not get into it. I mean, seriously.
Well, hopefully they would know that having reviewed some of it.
It's also called the art of nursing.
Yeah.
The art of nursing. And it's beautiful work.
Yes.
Did you say that these are also Medicaid residents from Harborview, or are there anyone?
Anybody from Harborview. Anybody from Harborview that we've been working with to develop a care plan. Anybody who comes out with a care plan that we've set up with them that we've found helpful. And now we just want to be sure that the transition goes smoothly and that the care plan elements don't get lost in the transition,
On your website with John.
Okay, yeah. So our final chat today, because we've heard a lot of sort of feedback / concern about contact precautions, infectious issues like MRSA, C. diff, Hep C, and so we wanted to give Dr. Dellit an opportunity to answer any of your questions. Dr. Dellit's an associate medical director here at Harborview Medical Center, is an ID doc and has run our infection control program for quite a number of years. So I'll turn it over to Dr. Dellit.
My name's Tim Dellit, so feel free to ask questions. As Liz mentioned, I'm one of the associate medical directors here, and for about 10 years ran our infection control program and actively practice as an infectious disease physician here as well. And the real question that we wanted to raise with you is sometimes it's confusing, right? When you see certain precautions taken in a hospital, and what do you do when the patient is either at home or goes to another facility or an adult family home? What do we need to do with that patient during that transition? So I wanted to just start with a couple of questions. So how many of us, raise your hand, how many of you have bacteria on your skin? Right? So we're starting easy. How many of you have bacteria in your gut? Good. How many of you have heard of universal precautions? Do we still use that term? Yes. No, we don't. So universal precautions came around in the 80s, right, when we started to see concern around HIV, hepatitis B, other bloodborne pathogens, because I can't tell by looking at you what you may or may not have in terms of bacteria on you or viruses, right? And so there are certain basic level of precautions and practices that we do with every patient all the time, because we don't know who may be colonized with a resistant organism or who may not, right? And so there's some basic principles. That now morphed from universal precautions. The term we use now is standard precautions. So think of it, these are standard practices that should be done with every patient, every time. All right, the cornerstone of which is what? Wash your hands, absolutely, hand hygiene. And hand hygiene in general can be either soap and water or the alcohol-based product, right? The Purell type of a product. So you can use either one. They're both effective in killing the organisms. If you use the alcohol-based product, sometimes you'll notice it's a little grimy over a period of time. It's very effective at killing, but you don't have that frictional get it off your hand. And so periodically you're going to want to use soap and water as well, right? Now also part of standard precautions is, let's say if I have a patient with a wound. If I have a wound, what do I want to do if I'm doing the dressing? What do I want to use? Gloves, right. So again, I don't know what's in that wound, doesn't really matter, but if I'm going to have contact with open skin, a wound, mucous membranes, then I want to protect myself, as well as actually protect that open wound from me in terms of putting any new bacteria in there. And so in those situations, I want to wash my hands, I want to put on gloves. If it's a big wound, sometimes we use a gown if we're concerned that there may be contamination of my clothing, right? So we use a gown. It has nothing to do with what the patient may or may not be colonized with. These are just basic practices as part of wound care in that situation. Now, hopefully in most of your situations, you aren't going to be having patients who are actively coughing, though occasionally if you have someone with COPD, they may periodically cough. And if you are taking care of a coughing patient, again, you want to be able to use a mask and protect your eyes, right? And those little glasses that we all wear don't really count for eye protection. But those, again, are basic things that we do for any patient, anytime. In the hospital, because we have a very vulnerable patient population that are at increased risk for healthcare-associated infections, and often their immune system is depressed because of their concurrent illness, what led them into the hospital. In those situations, sometimes we will screen individuals to see, well, do they have a resistant organism that they may be colonized with? In some situations, for instance, with MRSA, and actually, by the way, it's a law in this state that every patient admitted to the ICU has to be screened for MRSA upon admission. Now, I may just have MRSA in my nose. In fact, if I stuck a swab up all of your noses, how many times would I find Staph aureus?
90%.
It's not quite that high, about 1 in 3. So 1 in 3 of the world population, we all carry Staph aureus right in the front tip of our nose. Now, in a certain portion of individuals, it's probably about 2 to 3% of people walking around healthy in the community may have something called MRSA, which means that Staph aureus is resistant to certain antibiotics. Now, that may just be in my nose. I may not have an infection at all. I'm just carrying it as one of my millions of bacteria on my skin and in my gut. I don't need antibiotics to treat it. It's just there with me. The problem is, particularly in a hospitalized patient, is that sometimes things we do to them by putting a central line in or having surgery allows that bacteria to get from the outside where it's not causing any problems to the inside where they can develop an infection and then require treatment. And so in the hospital, we do use what's called contact precautions for people who are either colonized, meaning they may not have an active infection, but they happen to have that bacteria on their skin or in their nose. And that means that we use gown and gloves in addition to hand hygiene when we go in to care for that patient, in part because of concern that by contacting that patient, and especially if I'm not very good at washing my hands, do I run the risk of transmitting it to another patient, right? With Clostridium difficile, which is diarrhea, right, or norovirus, which is wide out there, unfortunately, now in the community, as you may have seen in the papers. If I'm having diarrhea, we also use precautions because, one, it's just gross, right? I mean, you don't want to go in there and touch and poop with your bare hands, so it's good to wear gown and gloves when you're going in there and taking care of those patients. But when those patients transition home, and you look at that living with MRSA, what we do in the hospital, these are based on CDC recommendations. The CDC, even when the patient comes back to an outpatient clinic or outside of the acute care hospital, they recommend just standard precautions for the care, even with respiratory MRSA.
So, you know, the state has told us, I actually had a patient that was discharged from the hospital with respiratory MRSA when we took it back, and I was not able to because they were not allowed.
What is respiratory MRSA?
It's in the lungs. I mean, and they're coughing and doing all kinds of stuff and spewing things, and we have no way of isolating appropriately in our adult family homes. So I was told I couldn't take her back, or else I would be cited.
So that's an interesting, again, not based on any CDC recommendation, that's just a made-up thing from the state. Just to be honest with you. If they're coughing, or even if I had influenza, if I cough, it can go into those large droplets that fall within 3 feet of me, but it's not airborne. It's not, I could have MRSA in my lungs and cough it up, and it is not going to hit the people at the end
So
of the
you're
table.
saying that it's perfectly fine then that we take patients with respiratory MRSA that are coughing and hacking things?
That is a state, if the state is telling you that, I can't control what the state tells you. I'm just saying.
John, you're not the state.
I'm just saying, but what I'm saying is, in that sort of situation, it's part of standard precautions. If I'm caring for a coughing patient, I don't care if they have MRSA or if they have pneumococcus or whatever organism, because we all have bacteria in our mouth. But in that situation, if I wore a mask and eye protection, I would be safe in caring for that patient. And then I wash my hands.
And the
as
other
well.
residents that are living in the home are safe as well.
What I would do with any coughing patients is I would probably try to keep them separated during their coughing illness, right? But again, it's not airborne. It's not going to go into another room. But I would try to, if they stayed in their room, I think that would be, again, I'm not a regulatory person, that's why I can talk freely. But that is typically what we would do. That is less common to have the kind of an MRSA pneumonia, or quite frankly, hopefully, if they have an MRSA pneumonia, they've been treated in the hospital, and then by the time they come to you, their symptoms are hopefully either resolved or very close to resolved, where their risk of infectivity is incredibly low.
Talk to the state once we find out who from the state that we can talk to. I don't think it's Mr.
No.
What
I would say also is that we also, sometimes we get that reaction from the state of Washington when we're talking about that, they have that concern about that other resident, but it's also very important to go back to the conversation about, what do our rules allow? And what is appropriate for this resident, what is going to be the best in their care interest. And if it's being in the hospital longer, or if it's coming to the adult family home, there isn't a regulation in the WAC or in the RCW that says you can't isolate a patient who's having this coughing fit. And that would be completely appropriate, on a care plan. So I'd be happy to talk to you in more detail about your specifics of your situation. But I guess I would always ask that regulator, can you point to me to the rules that don't allow or do allow me to manage the situation?
Because not all rules are based on evidence and solid clinical practice,
Because
right?
again, even in the hospital, the CDC does not recommend droplet precautions for MRSA pneumonia.
Right.
They recommend contact precautions, and as part of standard, if you're taking care of any coughing patient, you're going to wear a mask and eye protection. Okay, so sometimes there's confusion on that. The more common with MRSA is that it happened to be either a wound, or even more commonly, it's just the person was colonized and they have no active infection. They're not on any antibiotics for it. They just happen to have been colonized. In those settings, the pamphlet that you have, which is a great pamphlet that was put together by Pierce County Public Health, really focuses on hygiene in the home. So the hand hygiene, not sharing toiletries, not sharing razors, not sharing towels, those sorts of basic hygiene things are the things that we emphasize, and that's whether the patient is going home, because sometimes the question comes up, gosh, can my grandchildren come and see me? And sometimes people have this idea that, no, I can't see my grandchildren anymore. And of course not. Okay, all you need to do is wash your hands and basic hygiene, and it's fine to have those individuals visit. With C. difficile, more commonly than not, by the time they would come to you, their diarrhea has resolved. Now because our rates were higher than what we liked, we made a policy that we keep them in isolation even after their diarrhea has resolved, in part because that environment in which they're in is still contaminated. But with their diarrhea resolved, if they came into our clinic, if they came back to the ED, if they go to the SNF, if they go to adult family home, we would not recommend, and again, it's not my place to tell other agencies what they would or would not do, but we wouldn't isolate them once they're out of the hospital. The hospital is a unique environment where you have a lot of both critically ill and very vulnerable patients in very close proximity. Once they are well enough to be out of that hospital environment and their diarrhea is resolved, there's really no reason that they would require that. Again, it's basic principles of hygiene that are important. Now, back to what led to universal precautions. Initially, HIV, Hep B, hepatitis C, I know has come up, and hepatitis C actually probably the most common bloodborne pathogen. Half the people in this country infected with Hep C don't even know they have it. So the CDC is really pushing that we test everyone, actually.
I have a question about that, because they keep printing, I've seen commercials about that, like this baby over age.
Yeah, the 45 to 65.
Right, so how did they come up with it?
Well,
Because they had lots of blood transfusions or what?
Part of it is just targeting a population that was prior to when we started to screen blood, and back in the 80s and so forth. And so part of it is just trying to identify what is that potential at risk. In an ideal world, probably should offer it to everyone. HIV is recommended to be offered to everyone at least once, just as part of routine care. The same way I would check a glucose level, check an HIV test. We need to remove that stigma and just treat it like any other medical condition, and a chronic medical condition if it's HIV. Hepatitis C, now with these new drugs, 95% are curable, which is amazing compared to where we were when we used to use interferon. But the bottom line is, the only way these are transmitted is through direct blood contact with either you have to have broken skin or share the needles, right, inject, or inadvertently draw blood and then unfortunately stick yourself, right? or through a blood transfusion, but they are not transmitted by casual contact or the types of interactions that you would be having with a patient in an adult family home. Yeah.
Can you eradicate MRSA carrier status?
So that is a hotly debated question. In the hospital, I would say no, and we tried that for a little bit, but in the hospital, you have a lot of selecting pressures. You're still in that healthcare environment. Often people are still on antibiotics, which can further select for resistant organisms. Sometimes once you get a patient out of the hospital, their wounds have healed, and they get back to a normal functioning existence, so to speak. We in the clinic then can potentially try using mupirocin, which is Bactroban nasally twice a day for 5 days, and sometimes we'll combine that with chlorhexidine baths. But
And the mouthwash?
not always. It depends on where they're colonized.
Do you recommend testing the nose, throat, and hairy area?
Well, so we do in the hospital. At home, I don't recommend testing anything.
But if
Unless they're having
somebody
symptoms.
gets banned from adult family homes because somebody's identified them as carrier status, I was looking if there was a protocol.
But my argument would be they shouldn't be banned.
It doesn't matter. The provider can say, no, I'm not taking it.
But I think,
I will say,
so
once
what
we,
we should
just a
do
second,
there.
so I think one thing we have done here is that we've actually had Dr. Dellit call providers in person and say, let me explain this to you, let me help you understand, blah, blah, so that has worked. Now,
Yeah, that's what I was going to suggest, because usually once we have that conversation, they usually, it calms the fears, and then there's really not an issue. At least in the conversations I've had, I'd be happy to continue to have those conversations as well. Because again, I think, we only know they happen to be colonized because we had to test them because they got admitted to the hospital. We haven't tested all the other people who are just walking around in the community, again, harmlessly with it in their nose. And so I think the testing is a quandary in terms of the downstream impact. But I think in those situations, we'd love to have a conversation with them to see if we can try to explain what those real risks are or are not, and then discuss how they can try to care for that patient. And usually once we have a conversation with them, then they're fine.
So mupirocin and then like chlorhexidine gluconate showers for what length of time, like once a week, for how long would you say?
There's not a set protocol for that, so it really depends on the individual situation. Sometimes, if we see a clinic patient, we'll say do 5 days of mupirocin and do, every other day with chlorhexidine for a week. It just varies by individual, but I would say we usually more often try to do that if we know they're going to come back for a subsequent surgery or some other healthcare intervention. But if they're just going home, I would say the vast majority of people, we don't try to decolonize. Now, the other thing that's interesting about MRSA colonization is that a third of people will never be colonized. It's a hostile environment in their nose, and the bacteria just don't like it. A third of individuals will always be colonized with Staph aureus, and a third are what we call intermittent carriers. Meaning, if I swab today, I may find it, and if I check in 2 weeks, I may not find it. It's intermittently there, it's not constant. And so that's the other challenge with those, is that the predictive value of a one-time swab is not that great either.
This is a lady over a period of 3 or 4 years has had 3 separate incidents. UTI and a wound on 2 separate places in her body. So then, if it's been a number of years with 3 incidents, then what do you say?
Well, if she was in the hospital, we would use precautions.
She's in the community.
But in the community, I would just wash my hands. I would use gloves when I am changing her dressing. But I wouldn't do anything else differently other than the hygiene pieces, which I think are important for all of our patients. Because again, you don't know what you don't know. Just because I know this person has the disease, I don't know what this person has. The amazing thing, if you look at professional athletes, right? These young gentlemen making millions of dollars, right? But they share deodorant. They'll get in the hot tub together with open wounds, right? They're gross. They wonder why they get, periodically, they'll have a transmission of MRSA across the team. right? Of these $1 million athletes, because they just don't do basic hygiene. If we do basic hygiene, I don't think we have anything.
You know, I think what she's asking is, right, I think what she's asking is, would you not want to get rid of the bacteria for her own protection if she's continuing to get infected?
The trouble is, it's not always effective. So I think if I were her provider, yeah, I would try. You could try it. Now, whether it works long term or not, that's the other question. Because sometimes individuals, you know, if they're living in a certain situation that they got exposed in the first place, they may well get exposed again, right? So again, that's the challenge with, you can decolonize someone, but it doesn't give them immunity.
And I think the challenge with that is it lulls you into this false sense of, well, now they don't have MRSA, so I'm not going to wash my hands, I'm not going to do whatever.
So your guard goes
that shouldn't preclude us from taking care of these owners. So again, thank you, Dr. Dellit.